Good evening, everyone. Good evening to one and all. This is Dr. Ritu Johari from Abbott Diabetes Care, and I have with me today esteemed guest of honor, Dr. A.G. Unnikrishnan from Pune. While he needs no introduction, let me quickly just take the honor of introducing his credentials on this platform of TalkPlexus. He's one of the leading endocrinologists, as you know, and is currently working as a CEO and Chief of Endocrinology at the Chilaram Diabetes Institute at Pune, which is one of the state-of-art diabetes institutes in Pune, where he leads research, clinical care, has several educational programs, and also philanthropic care programs for diabetes run at this institute. To his credit, he has n number of national as well as international publications, has delivered more than 100 lectures as we talk. They go on increasing on national as well as international platforms, conferences, educational networks, and additionally, he is a winner of prestigious awards such as Jacob Prize for Best MD from CMC Vellore. Starting there, his journey has been filled with awards, including the prestigious VR Joshi Award, the JAPI Award, Endocrine Society of India Award, the Srivastava Award, RSSDI Award, and also an Endocrine Writing Excellence Award for the Best Consensus Guidelines in Indian Journal of Endocrinology. There are many more, but then I just thought that it will be very nice for us to spend more time in hearing from Sir himself about significance of blood ketone monitoring in diabetes. So as our topic says today, we're going to talk about decoding the significance of monitoring blood ketones in diabetes. So without further ado, may I request Dr. Unnikrishnan to please take over the session for today. Sir, over to you.
Can you see my screen?
Yes, sir. We can see you and also the slide on the screen.
So am I audible?
Yes, very loud and clear.
Thank you. Thank you, Dr. Ritu. It's a pleasure to be giving this lecture on DocPlexus, a very short lecture on the on how to decode the significance of blood ketone monitoring in diabetes. So I'm going to talk about significance of blood ketone monitoring in diabetes because we know that blood ketones are routinely tested in hospitals and also in clinics. But what about testing blood ketones at home? So that's going to be the focus of my presentation. So this is the outline of today's short presentation. I will first look at the clinical importance of diagnosing diabetic ketoacidosis. I will revisit the basics of ketones and their importance. I will talk about certain clinical aspects of blood ketone testing, and then look at some guidance, clinical guidance for special situations in type 1 diabetes. So let's begin with a case. A 16-year-old lady has type 1 diabetes, and she has been referred to the hospital with severe dehydration and ketosis. On questioning, it was found that she had been out for a picnic with her classmates and she hadn't disclosed that she had type 1 diabetes. She did not carry the insulin with her. When she came home, she found her insulin stores depleted, and then she was referred to the hospital. When she was referred to the hospital, her investigation showed typical features of ketoacidosis. The blood and urine ketones were present. There was severe hyperglycemia. There was leukocytosis. There was acidosis. With this situation, she was admitted in the ICU, managed with IV insulin infusion and hourly glucose testing, and she was soon shifted to the ward. So this is a case. Diabetic ketoacidosis occurred at home, and the patient was then shifted to the hospital. Let's look at another gentleman. Now, this is a 93-year-old gentleman with type 2 diabetes. He was again referred to the hospital with severe dehydration and ketosis. On questioning, he had been on metformin, insulin, and oral drugs. The family physician, because his blood glucose levels were going down, he wasn't eating well, had stopped the insulin, advised regular monitoring and SOS doses, but the glucose levels were not monitored well. So then he developed ketoacidosis, and for the first time, he was referred to a tertiary center. His random blood glucose level was 600. His HbA1c was 17%. He had typical features of diabetic ketoacidosis. The blood ketone level at admission was high. And again, like the person with type 1 diabetes before, this gentleman with type 2 diabetes was admitted in the ICU, managed with IV insulin infusion, hourly glucose testing. He soon recovered. So this is just to give you a highlight of the importance of ketone testing. And this is a slide which shows you how to interpret ketone testing, and this could be in the clinic or at home. Now, if the ketone levels are below zero point 0.6 millimoles per liter, it's considered as normal. Now, if the values are between 0.6 and 1.5, then that indicates that there is a need to change or step up the treatment. This also indicates that there may be a problem that may require medical assistance. Now, as shown in the red color, where the ketone reading is more than 1.5 millimoles per liter, this suggests that the blood glucose reading is high, that the ketone levels are high, and there is a high risk, there is a risk of developing diabetic ketoacidosis, and that this risk of development of diabetic ketoacidosis is high. So coming back to the case number 2, the 93-year-old gentleman with type 2 diabetes, you can see the blood glucose levels were very high, and with insulin infusion and IV fluids, his blood glucose levels improved and he became stable. And these are his ketone levels. Note that his ketone levels are very high, 8.1 in the casualty. Timely starting of insulin infusion and glucose brought down his ketone level to 5.1. Further came down to 1.1, rose up a little bit. So these are all examples of blood ketone measurements. And you can see the ketone levels coming down and staying down in the ICU and later in the ward. But my point is that in these two cases, could these two serious cases have been prevented by better home monitoring of glucose? So that's the point I'm trying to make here. Could these two serious cases have been prevented had the glucose levels been tested, had the ketone levels been tested? Could this have been prevented? Maybe one thinks so. It is always possible, but that, ladies and gentlemen, friends, is the clinical importance of early diagnosis of diabetic ketoacidosis. Now, in this background of diabetic ketoacidosis, I want to revisit some of the basics of ketones and their importance. Now, let's look at how ketones are formed, because before we monitor blood glucose, blood ketones at home in diabetes, it's important to understand how they are formed. So ketones are formed when the body breaks down fat for energy. Now, when there is a lack of insulin, ketones increase and disrupt the delicate balance of the body's chemistry, and that causes diabetic ketoacidosis. But whenever the body breaks down fat and uses the fat for energy, ketones are formed. And this happens when carbohydrates are not available. When the carbohydrates are not available, for example, if we start starving, our body starts making glucose from the glycogen stores in the liver. But generally, the glycogen stores in the liver last only for a day. So after a few days, the body requires energy. And when there's no carbohydrate coming in, when there's no glucose being formed, when there is a lack of energy, the body starts making ketones and breaks down fat to make that ketones. The body now must burn fat for energy when there's no carbohydrate available, and this fat burning leads to ketones body production. And to some extent, when we all starve, we should not be starving, of course, but when we don't eat food for a period of time, this is the body's adaptation to produce ketones in situations where we cannot eat. So this has been a metabolic adaptation, but this process needs to be regulated by enough insulin. And when there is not enough insulin on board, this ketoacidosis, ketone body production becomes unregulated. Excess of ketones cause acidosis, hypotension, dehydration, because ketones are water soluble, ketones are lost in the urine, and acidosis, ketosis, dehydration, hypertension all lead to a very dangerous catastrophic disease called diabetic ketoacidosis. So type 1 diabetes with a lack of insulin is the number one condition leading to diabetic ketoacidosis or ketosis. But certain types of type 2 diabetes, especially long duration type 2 diabetes, where the body is stopped making insulin, that's insulin dependent type 2 diabetes, can also, when insulin is withdrawn, can cause ketoacidosis. Certain genetic types of diabetes, certain euglycemic ketosis, certain drugs like SGLT2 inhibitors can produce ketosis because they cause glucose loss in the urine. The fat is burned to get ketones. But the importance of this condition is that the blood glucose levels will be normal. Certain fad special diets like intermittent fasting diet, ketogenic diets, now these are diets that produce ketosis. Now, nutritional ketosis in non-diabetes individuals happens when dietary carbohydrates are significantly reduced to less than 50 grams per day. And then the body increases its ketones to maintain values over 0.5 millimoles per liter. Now, this kind of diets are not recommended generally in type 2 diabetes and obesity, and generally should be avoided in many people, and I will not focus on this aspect. Coming back to blood ketones, when the glycogen stores are depleted, as I mentioned, the fat in the body is burned to produce ketones. There are ketone bodies, which are three in number: beta hydroxybutyric acid, acetoacetate, and acetone. Beta hydroxybutyric acid and acetoacetate are released in large amounts into the bloodstream. This increase in ketones will reduce the pH and cause acidosis. As I said, you have three ketones: acetone, which is detected by the fruity order, as we used to read in our medical textbooks. Acetoacetate got by combining two molecules of acetyl coenzyme A. And then from acetoacetate, beta hydroxybutyrate is formed. Of course, acetoacetate can also get converted to acetone, or acetoacetate can get converted to beta hydroxybutyrate. Beta hydroxybutyrate is typically detected by blood ketone measurement, whereas in urine ketone measurements, you have a lot of other ketones like acetoacetate as well as beta hydroxybutyrate detected. Now, the important thing is that beta hydroxybutyrate, I want you to focus on beta hydroxybutyrate, because in diabetic ketoacidosis, though there is plenty of glucose in the blood, without insulin, the glucose cannot enter the cell. So the cell, inside the cell, there is no glucose. And beta hydroxybutyrate can be used as energy. So therefore, ladies and gentlemen, how to differentiate between beta hydroxybutyrate and beta hydroxybutyrate plus other ketones. So how to differentiate between urine ketone and blood ketone testing, because that's important in all the catastrophic hyperglycemic states such as diabetic ketoacidosis, and you'll also be aware of the hyperosmolar hyperglycemic state. In hyperosmolar hyperglycemic syndrome, ketones aren't produced in large amounts because there is some insulin on board. But in diabetic ketoacidosis, blood and urine ketones are high. But what are the nuances to differentiate between these two? So I've looked at the importance of diagnosing diabetic ketoacidosis. I have discussed the basics of ketones. Now let's move on to some clinical aspects of blood ketone testing. So remember, this data is from a classic study from Shade and Eaton, and also published. And this shows you that after treatment of diabetic ketoacidosis, you can see the total ketone bodies coming down. You'll also see a steady, gradual decline in beta hydroxybutyrate. But you will see that there is a slight increase in acetone. Why does that happen? And that is because there is the conversion of beta hydroxybutyrate to acetoacetate during the resolution of decay. So you'll see the total ketones coming down, you'll see the beta hydroxybutyrate coming down, you'll see the acetoacetate increasing a little bit. So just to highlight that in the initial phase, while you may have the acetoacetate similar at the same level, you'll find the beta hydroxybutyrate rising, which signals ketoacidosis. Later on, you'll find that the beta hydroxybutyrate is getting better as you treat ketoacidosis, but acetoacetate is increasing. And that's because uh, beta hydroxybutyrate is getting converted to acetoacetate. So therefore, if you measure beta hydroxybutyrate, you'll know that the patient is getting better. But if you measure urine ketones, you'll find it paradoxically going up. But after a period of treatment, you will see that the similarities come back. But in the initial stage, beta hydroxybutyrate blood testing may be preferable to urine ketone testing. So, friends, since urine ketone test can only detect acetoacetate and acetone, remember, urine ketone test cannot detect beta hydroxybutyrate. Because of these problems, it is possible to misinterpret the effects and success of treatment, which can lead to over-treating the condition. As I showed you the slide, the beta hydroxybutyrate was coming down, but acetoacetate was paradoxically going up. Uh, a doctor treating diabetic ketoacidosis may get worried when he or she tests urine ketones because the acetoacetate is going up, urine ketones continue to be large, and may end up over treating the condition. But if the doctor does a blood ketone measurement, then the beta hydroxybutyrate will be detected as coming down, and therefore uh, the correct treatment can be prescribed. This means that urine tests for acetoacetate remain positive, their resolution lags behind, and therefore they are a false indicator of ongoing ketosis. There is also some inconvenience with urine ketone testing. People may find it inconvenient. So, urine ketone testing is hydration dependent. People cannot perform the test if they do not have the urge to urinate. Another limitation of point of care urine ketone testing is that it is qualitative only. Once the urine is placed on the strip, you have a change in color, and the changes in color may be difficult to distinguish and may be misinterpreted. And of course, there are false positives and false negatives with urine ketone testing. And additionally, people store their urine ketone tests in the bathroom where excess humidity can impair the accuracy of the urine ketone test strips. I'm not saying that we should not use urine ketone test. I'm just saying that in today's era where patients need it and can afford it, blood ketone or plasma ketone testing is superior. So, ladies and gentlemen, false positives can occur when urine ketone test strips are exposed to air for long periods. Sulfhydryl medications can interfere with the urine ketone test strip results. Highly acidic urine samples can impact upon results. The test is qualitative and not quantitative, so the user may have to differentiate between colors. Urine ketones may lag behind blood ketone levels. Urine ketones may remain positive for up to 24 hours after resolution of ketoacidosis, whereas if you measure beta hydroxybutyrate, you can see it coming down. So again, to re-emphasize, urine ketone testing measures acetone and acetoacetate. Beta hydroxybutyrate is a more important ketone in the sense that for measuring, it is a more important parameter for showing resolution of ketoacidosis, and it's also a more accurate test with less interferences, so on and so forth. So again, to show you that here is a situation where the beta hydroxybutyrate can rapidly come down, whereas the urine acetoacetate can remain positive, and therefore it can interfere with the treatment of diabetic ketoacidosis. This is just to show you that a simple monitoring assessment, a checklist of blood ketone monitoring for medical evaluation can be performed at home. Now, if the blood glucose levels are very high, more than 250, that means hyperglycemia is sustained and ketones may be tested. Now, if the blood ketone target is less than 0.6, that's normal and you don't have to worry. If it's 0.6 to 1.5, you need to reassess that because the person may have impending ketoacidosis. If the blood ketone level is 1.5 to 3, then you need to consider a workup for ketosis and augmenting the insulin. And if the blood ketone level is more than 3 millimoles per liter in a hyperglycemic person with insulin dependent diabetes, you need to consider a clinical workup of diabetic ketoacidosis. You need to do the pH testing, bicarbonate, anion gap testing, so on and so forth. This is a rough guide to interpreting the blood beta ketone reading. As I mentioned, below zero point 0.6 millimoles per liter is normal. Between zero point 0.6 millimoles per liter to 1.5 millimoles per liter is borderline. Above 1.5 millimoles per liter suggests that the risk of developing ketoacidosis is high. So when to test for beta ketones? I think any type 1 diabetes or insulin dependent type 2 diabetes or type 2 diabetes person taking medications that may increase the risk of euglycemic ketosis uh, has blood ketone facilities at home. During acute infections and fever, blood ketone should be tested. Whenever there is nausea, vomiting, diarrhea, abdominal pain, fruity odor of breath, rapid breathing, excess urination, fatigue or lethargy, beta ketone testing must be performed. Now, we've looked at the importance of DKA. We've looked at the basics of ketones and their importance. I've shown you the important aspects of blood ketone testing, shown you the difference between blood and urine ketones. Let's look at special guidance in type 1 diabetes. Whenever a type 1 diabetes person is going to do exercise, uh, that person has to check the blood glucose levels. If the blood glucose is more than 270 high, then it's better to check blood ketones. If the ketones are slightly high, if it's below 0.6, nothing to worry. If it's 0.6 to 1.4, exercise should be restricted to a light intensity for a brief duration, may need corrective insulin. Remember, this is for type 1 diabetes, insulin-dependent type 1 diabetes occurring in the young. Now, if blood ketones are elevated to more than 1.5 millimoles per liter, that person should not do exercise, control the glucose, stabilize, and then do exercise. These are international guidelines, and these are the recent UK guidance on managing type 1 diabetes with multiple insulin injections at home during the pandemic period. The guidelines suggest that it's better to have a 2-in-1 solution, a blood glucose meter and a ketone test kits, either blood or urine, and these must be kept handy if the person is on multiple daily insulin injections. And of course, if the person feels unwell on multiple daily insulin injections, blood glucose testing and test out. And if ketones are present, blood glucose must be tested every 2 hours. And if ketones are persistently positive, medical help must be taken. And it's important to note that critical uh, testing of blood ketones at home can guide people with type 1 diabetes at home, especially when they are unwell with an infection. This is just to highlight that sick day rules are important, but there are other aspects of sick day rules in type 1 diabetes. It's important to take enough carbohydrate containing fluids if the person is sick and having fever and not eating. Fluids are important also to prevent dehydration. To prevent nausea and vomiting, small sips of liquids are important every 15 to 30 minutes. To prevent starvation ketosis, approximately 150 to 200 grams of carbohydrate minimum must be taken if somebody is sick with a viral fever or any other intercurrent illness. So friends, I showed you 2 cases of diabetic ketoacidosis to highlight the importance of DKA. I suggested that ketone testing may be important, and I looked at the 3 ketones: acetone, acetoacetate, and beta hydroxybutyrate, and showed you the importance of blood ketone testing, which measures beta hydroxybutyrate, which is an important marker of diabetic ketoacidosis, and talked about the limitations of urine ketone testing and how acetoacetate testing lags behind. I also now ended by looking at clinical considerations for type 1 diabetes people before they exercise and before they get infections, how they can follow sick day rules. It has been an absolute pleasure discussing this topic with you, and thank you. Thank you for listening to me. And over to Dr. Ritu and the rest of the team.
Thank you so much, Dr. Krishnan. I think it's been a really very, very lucid presentation, and I'm sure the audience will also love to, ask us questions. So, meanwhile, I had just, a couple of things that were building up in my mind, sir, while you were presenting. One, I must congratulate you because you started the session with using cases. And that kind of really brought us to a level of direct clinical relevance. Because today we understand that there are a lot of webinars that are happening. And therefore, it becomes pretty important that in every session, scientifically, when we are inclined to learn, how do we take those learnings back into our clinical OPD and thereby be able to apply that to our patients? So, really, thank you for that effort. Moving forward, I really had one point from your elaboration that I feel would benefit our group of audience is that people feel monitoring in India itself is very niche. It's not optimal today. It's not mandated. And therefore, when it comes to ketone monitoring, it becomes really very, very minimal if you look at all the states across the country. And the situation is still not even different globally. How do you like to position ketone monitoring in your patients, and especially coming out of the dilemma where people still have the notion that monitoring more is required only for type 1s and not type 2s? So, how would you like to position that for this audience, sir?
Thank you, Dr. Ritu, for that question. I think you are right. And in India, maybe because of several factors, glucometers, the glucometer strips, and so many other factors are there. Uh, the perceived cost of the glucometer. Now, I'd like to say that the perceived cost. I'm using the word the perceived cost of the glucometer because the person who uses the glucometer or uses a glucometer strip perceives it as expensive, but the value of a glucometer, especially a glucometer which also gives you the additional facility of being able to test for ketones in some cases. So having a glucometer is very important because a person will know whether your blood glucose is high or low. Sometimes patients with diabetes, they say, doctor, I think my glucose levels are high, but I haven't tested. But I always tell them, please test, because sometimes you might get similar symptoms if the blood glucose is high, and you might feel tired if the blood glucose is low. So it becomes important to test. The second is an issue of ketone testing. I think that's been a very, very important area where I think, especially people with type 1 diabetes, we know now type 1 diabetes can occur at any age. I think we need to raise the bar as far as ketone testing is concerned. But I would like to just add this point is that ketone testing in type 1 diabetes is needed to prevent ketoacidosis and during the treatment of ketoacidosis. So somebody at home, if the blood glucose is high, they're not feeling well, if they're feeling like vomiting, a simple blood ketone test will tell them if there is impending ketoacidosis. They can simply aggressively take more fluids if possible. If they can take fluids, increase the insulin dose, and can sort out the problem. And if the ketone levels are high, they can reach the hospital before it becomes a calamity. So that's the preventive role. Wherever people uh, can benefit from ketone testing and can afford it, I think ketone testing is very important.
Thank you, sir. I think that's pretty well put up. And I think that also brings up one point to my mind that, while we do have a lot of data that talks about health economics, there is also this correlation that monitoring itself can actually impact upon the direct and indirect costs that are associated in medicine, which means that if today we can ensure having the monitoring in place, exactly like you said, these patients can avoid their pockets burning from additional unnecessary hospitalization, probably the ketoacidosis, and the rather difficult or more complicated situations that arise from this particular situation. And also, again, I think that really made a very good strong point here that not only type 1s, even the type 2 patients can have ketoacidosis, and can get complications or admission to the hospital. So we need to keep our minds open when these patients come to us. Let me bring on some very common questions, sir, which I have encountered, which people ask me. which is about, have you heard about the keto diet, and can I take this keto diet? So, sir, maybe just your views on keto diet, because that's a debate which runs and is something that we would really want people, audience here, to know from you, that how should we be careful in the diabetic population per se, when it comes to observing keto diet, and any observations or knowledge that you could share on what kind of difference does it make to create ketosis versus the ketoacidosis in diabetes.
So, ketosis is different from ketoacidosis, and uh, do a, when people do a keto diet, they achieve what is called nutritional ketosis, or purposely they achieve ketosis. Now, a nutritional ketosis, as I said, the first keto diet consists of cutting down the carbohydrate intake. But many people think that by just cutting down carbohydrate, they can go keto. But it depends on actually increasing the fat intake. So, cutting down the carbs, taking a huge amount of fats and a little bit of protein is what is the keto diet. Now, on keto diet, people on the keto diet initially have something called keto flu. They feel feverish, they feel dehydrated, they have to drink a lot of water because ketones are soluble. They start losing ketones in the urine. In that stage, the urine ketones may be tested, but in the later stages, when they've achieved the nutritional ketosis, there's no ketone, and the urine ketone test may be negative, and then really they depend on blood ketone levels. And I've heard and I've read that a ketone levels of up to 3 or 4 millimoles per liter are safely tolerated by these people who achieve ketosis. So, keto diet has an importance in losing weight, in reversing type 2 diabetes, but I must warn you that it's not for everybody. So, a keto diet should not be tried. Obviously, in people with type 1 diabetes, if they go keto, it can be very, very dangerous. They can get ketoacidosis. Of course, there are still people trying that, but it can be very dangerous. Second group of people on SGLT2 inhibitor, a group of drugs which throw out glucose in the urine, they cause ketosis. So those people should not be on a keto diet. Keto diet may not be sustainable in the long run. Any diet that anybody takes has to be nutritious, healthy, tolerated, and sustainable. So all these things are not there in the keto diet. Of course, an occasional patient may be able to sustain a keto diet. You must check with your doctor. But keto diet comes with it a lot of pluses and minuses, and you have to really balance it out. On the balance, I'd say to wait for some more time. But yes, ketone monitoring with blood ketone testing seems to be important in nutritional ketosis.
Wonderful, sir. Thank you for that one. I think that really makes it very easy for us, because today, what has to be used, the information, where do we go for, is very critical. And therefore, thanks for bringing light to that particular subject. Now, let me get you back on the monitoring aspect, since today we are talking about decoding the significance of ketone monitoring here in diabetes. So, how frequently would you want our fellow colleagues to advise their patients of type 1 and type 2 to monitor ketones on a general basis? As you said, that if they have the glucose meter, there are meters available that have both glucose and ketone monitoring in the same device. So, how frequently would you advise them, or when do you think would you advise them to monitor their ketones?
So I think there are some established indications. Let's begin with type 1 diabetes. Now, a type 1 diabetes person, if that person is using a glucometer, wherever the blood glucose levels are more than, say, 270 or 300, and if the person is feeling down, dehydrated, lethargic, fatigued, that person could check the ketones. Second, if you see the exercise guidelines in type 1 diabetes, where the blood glucose is more than 270 prior to exercise, they need to measure ketones, because when you exercise, you are actually going to accelerate that ketogenesis. So if the ketones are maybe trace, you should maybe correct the glucose with a small correction dose of insulin and then do a light workout. But when the glucose levels are very high and ketones are 4 plus, 5 plus, or blood ketones are, say, 1.7, 1.8 plasma ketones, blood ketones, I think that's a time when that person should dehydrate, take an insulin dose, bring down the blood glucose, stabilize. So that's in type 1 diabetes. Needless to say, any type 1 diabetes person who falls sick, ill, not able to eat, that could be because of a fever or a viral infection or some other disease, diarrhea or anything else, should monitor the ketones. In type 2 diabetes, supposing they feel unwell, fatigued, lethargic, and they are taking insulin, insulin dependent type 2 diabetes, again, the same criteria applies. And of course, uh, while it's not necessary to monitor ketones in type 2 diabetes on SGLT2 inhibitors, I think the possibility of euglycemic ketosis should be considered if the person is sick, uh, ill at home with fever, and on SGLT2 inhibitors. So these are some of the indications, but the major indication is type 1 diabetes with nausea, vomiting, persisting, and additional sickness, not able to eat. I think ketone testing very important and should be repeated every 2 to 4 hours. Sometimes relatives say that the person has a fruity odor of the breath. That's also something that in type 1 diabetes that you need to test ketones.
That is a brilliant one, sir. You just gave me my next question. While you have covered, the signs and the symptoms, that how do we recognize keto acidosis in these patients? Is there any case where you have seen, or you would want to, suggest that how do they mark up that this is probably an aura or a feeling of beginning of ketoacidosis? One, of course, you mentioned just now is the fruity odor or smell of fruity smell of the breath. Anything else that gives them an idea of the rising sugars or the dehydration that you would want to bring in?
Yes, yes. So I think simple clinical markers, if that person is feeling fatigued, lethargic, if the tongue is dry, not able to drink water, has persistent nausea, vomiting, abdominal discomfort, shortness of breath. I think these are all in type 1 diabetes markers of an ongoing ketosis, and that's a time when ketones should be tested.
Wonderful, sir. And sir, generally, I mean, I do agree that you have been mentioning from the start, and it's very evident that in your cases, you found merit in observing, monitoring in these patients that were hospitalized, the type ones as well as the type two. Do you, in your patients, what percentage of your patients would you like to observe monitoring when it comes to glucose as well as ketones?
So I think every type 1 diabetes, they say that to know diabetes is to say no to diabetes. So every type 1 diabetes person uh, in our hospital go through a very strict educational regimen where they are made aware of all aspects. And one of those aspects is diabetic ketoacidosis. Because while we do not see diabetic ketoacidosis as commonly as maybe I used to see 20 years ago, nowadays ketone testing has really helped prevent diabetic ketoacidosis. So every type 1 diabetes, I would like to tell them about what is diabetic ketoacidosis, how does it occur, what are the symptoms, how insulin deficiency can predispose to ketoacidosis, and how they could test, prevent it, and also get in touch with their medical doctor. Now, in type 2 diabetes, I never used to mention ketoacidosis because it's very rare. But nowadays, with people with diabetes living longer, we have a lot of type 2 diabetes people who are really insulinopenic after decades of type 2 diabetes. They do not have any beta cells, they are on basal bolus insulin, and they may be at risk. While I do not mention ketone testing to them, if they are on SGLT2 inhibitors, which means if they are on additional drugs, which they should not be, of course, but if type 2 diabetes people are on SGLT2 inhibitors, I always them, look here, if you're on this group of drugs, do not go for any abnormal diets like keto diet or intermittent fasting diet, because you may make ketones in your blood and in your urine. And maybe it's a good idea that now that we have the widespread availability of blood ketone testing and also approved indications for ketone testing in clinical practice, that might be something which we could discuss with them. But yes, these are some of my thoughts.
I agree with you, sir. And let me allow me to just, also bring up to the audience that today it's very evident that people go on Google, people talk to their peers, they go on to their communities on social media, and they like to find out about diabetes, about ketones, about their drugs that they read. And therefore it becomes a very optimum responsibility of us to have them have given them the right amount of information when it comes to such platforms. And my next question, sir, to you is somewhere talking about there are various kinds of strips that are available. And looking at the cost or the availability of these strips, do you see a difference when it comes to having a single wrapped strip, a single wrapped foiled strip, versus those that are available openly in a can? Do you find any difference in that practically or clinically in your clinic?
So it's a very important question, and when you, it's important to consider the real life situation. Now,
Yes.
supposing you are in front of a patient and then you have to quickly test the blood glucose level. You open the cap and you take a strip out. Maybe you are
Right.
touching the strip. Maybe you have touched the other strips. Maybe the other strips have been touched already. The other strips have been exposed already. Maybe you have taken a meal containing glucose and without washing your hands, you've touched the strips. Now, all this should not be done, but in real life situations, it's very difficult to keep control on every step, whether it is in the hospital or at home. So, having a single wrapped strip, in my opinion, is a little better because number one, it can avoid the contamination. If all the strips in a particular pack are kept loosely and you put your finger in and take out one strip, or take out one strip by putting it out like this, there is some exposure to the environment, there is some risk of contamination, there is some risk of oxygen exposure, and this can be as high as maybe 30-40%. So therefore, uh, I think, if a nuanced interpretation of mine is that maybe a single wrapped strip is better than the bulk strips that you get in practice.
Okay, sir, that's really very valuable. And then again, I'm just thinking of if I am practicing and the patient comes to me, the most important factor, whether it comes to a drug or a device, is the performance of that particular device. So, how would you like to comment on the accuracy of these ketone strips that we are talking about today? Because ultimately, this is what is going to influence our decision making in clinic or in hospital or at home as well.
The point is well taken. So, if you look at the accuracy of the ketone strips, first of all, let me look at blood ketones. The blood ketones can be trace, they can be negative, they can be trace, they can be mild, they can be moderate, and then they can be large. So I think the color changes, and that's not a very correct way of looking at it because number one, it lags and it's not accurate, and you have to differentiate between the colors. It's qualitative, but whenever you look at a blood ketone strip, one that measures beta hydroxybutyrate, I think you're looking at pretty accurate way of testing ketones, and therefore blood ketones levels are the benchmark for ketone testing. Now, in some countries, they have breath ketone testing. I'm not aware if they have it in India. That is something maybe to consider for the future. But like any test, no test in the world is 100% accurate. It'll come with its own limitations and nuances for interpretation. But yes, the concluding line is that a beta hydroxybutyrate based testing of the blood is probably the most accurate. So it is the best way of testing ketones we have now. So that's what we can tell about it right now. But yes, accuracy, I think everything has to be interpreted keeping the clinical situation in mind.
Great, sir. I think that's wonderful. And so then, I just heard from you about the breath ketone testing. And I was also going through certain literature online that is available in the public domain for patients as well as doctors. And clearly, every place they do mention that there are the three types of monitoring for ketones, especially with the advent of keto diet. I'm sure all of us and our patients are today aware about what ketones are. but probably not really clear on why urine, why blood, and why breath ketone testing. But to my little knowledge that I have, sir, what I have realized and I picked up from your talk as well is that beta hydroxybutyrate, out of the three ketones, the acetoacetate, acetone, and beta hydroxybutyrate, it still remains as the most accurate bit because of the lack of oxygen exposure and oxygen, the lack of the GOH or the GOX or the glucose oxidase potential, because of which it has the accuracy. So I think, would you also concur with me that when it comes to ketone testing, more than the breath ketone and the urine ketone, we would like to do the blood ketone because the cost per se remains the same for all three of these in today's time?
Oh, I completely agree. I think from what I can understand, breath ketone testing is not very easy to do because you need an app, you need a device. That device needs a battery. It has to be charged. You have to make a deep exhalation. It's not the same as a deep inhalation. You have to make a deep exhalation and then look at it. So I think using a GDH NAD technology, GDH NAD being an enzyme, and that enzyme based technology to measure hydroxybutyrate in the blood, I think that seems to be good. And if you can see that the whatever as a doctor, it's very difficult to look at, to find out if this device is approved or not approved. But if you
Right.
have something like, if it follows the ISO guidelines, which is probably the most recent guideline, if it follows these guidelines and it has that certification, I think you should go ahead and you can consider it. So maybe some of these things could be practical pointers when you look at ketone testing.
Okay, sir. I think, again, I'm practically just so happy that these kind of points are really coming up in this discussion so that, our audience can go back with these pearls of wisdom and use this technology in their practice immediately. And quickly, sir, the next question that comes to my mind is that on an average, when the patient gets ketoacidosis and is admitted with ketoacidosis, so it could be a type 1 or a type 2, as you shared the two cases that you had, how many days do you think hospitalization would be happening in these patients?
So, on an average, where the typical diabetic ketoacidosis is a pure insulin deficiency disease, and once you admit the patient in the ICU, you are looking at 24 to 48 hours in the ICU at the maximum. Some of these patients can even be managed in the ward also. There are guidelines now that you can manage them in the ward. So you're looking at maybe 4 or 5 days of admission at the most in many cases, unless that diabetic ketoacidosis has been triggered or precipitated by some underlying condition. And that is, if that is an issue, then of course it may take some more time. But a pure diabetic ketoacidosis, you're looking at 1 to 2 days stay in the ICU, 1 to 2 days in the ward. But I think that time spent in the hospital, we must educate the patient, make that person aware so that ketoacidosis does not happen again. And that is a time when the person with ketoacidosis is also most receptive to advice and suggestions. And that's why I think this time is very important, and we use this time in our hospital to educate the person completely about diabetes. And usually the type 1 diabetes, the ketoacidosis, when they get hospitalized, it's their first diagnosis. At
Correct.
diagnosis they get hospitalized because once they are
True.
aware, they monitor the ketones and they don't get it. So that's the time when you can give the entire spectrum of knowledge on diabetes.
Absolutely, sir. And I think, yes, while the type 2 still gets a good time period or a window to learn about this, probably the time window is much shorter for a type 1 because, he or she may experience more frequency of ketoacidosis or is more prone to ketoacidosis because of the genesis of type 1 itself or the nature of the disease itself. So, I really think so that this also brings to me on a point of note that because there is a possibility of monitoring, there is a tool available for monitoring which is as handy as our blood glucose monitoring and is done in the same meter. So why not just monitor the blood ketones well in advance, and then you can actually avoid two different things in your patients. One is the hospitalization which is caused, which is going to create a mental trauma, And secondly, there is going to be the pocket burn, which is going to be there for the 4 to 5 days of the hospitalization, even though the patient has or does not have an insurance. Knowing that India per se also is very low in terms of having the kind of coverage or mediclaim in this country.
Oh,
So,
absolutely,
interestingly,
doctor.
yeah, yes, sir.
Yes.
Sorry.
So I completely agree with you. If you look at the cost of testing a blood for ketones versus the cost of a hospitalization for diabetic ketoacidosis, there's no doubt that a stitch in time, they say, can prevent problems. So therefore, one simple test in time is able to prevent a big problem of hospitalization and so many other issues.
Absolutely, sir. Thank you so much for bringing that up. And we have one question from the audience, which is pretty interesting, which says that does C peptide assay identify type 2 DM patients with type 1 so that SGLT2 inhibitors can be avoided in these patients? So, can we, in basically, let me just rephrase this question for you, that before starting SGLT2 inhibitors, nowadays we are finding a lot of crossover between patients. Suddenly, a type 2 happens to be diagnosed as a type 1 or vice versa. So, can we use C peptide assay before prescribing SGLT2 inhibitors to confirm that these patients would not be thereby pushed into the dangerous zone of ketoacidosis?
I think that's a great question. I think that's
Yeah.
a really great question. Now, C peptide testing is quite expensive. And number two, C peptide testing may show a very high C peptide in type 2 diabetes. Now, because of these reasons, uh, it is better to depend on your own clinical judgment if a person is insulinopenic or not. So, somebody comes with type 2 diabetes for 20 years duration, is lean, thin, emaciated, requires insulin. I think that person is at risk of ketosis, and I would not prescribe an SGLT2 inhibitor. But somebody who's a classical obese type 2 diabetes coming into the clinic, and I think a simple urine routine test, which would show the urine, the chances, would be enough to help prescribe SGLT2 inhibitor. I don't think a C peptide would be required. Yes, from a research perspective, it's a very interesting question. If you do the C peptide and if you find a low C peptide, should you worry? But let me also tell you that hyperglycemia itself will suppress the C peptide. If blood glucose level is 300 or 400, the C peptide will be low. If diabetes is so these very same persons, when their glucose is controlled, their C peptides will improve. So C peptide is also a dynamic test. So because of these three reasons, the cost of the C peptide, the dynamic nature of changing C peptide level, the high C peptide, which if you give SGLT2 is not a guarantee that somebody may not get euglycemic ketosis because an infection or something else may push them into it. Because of all these reasons, I think a C peptide may not be an ideal test to predict SGLT2 ketosis, but could be a good research idea to a protocol to see whether in the long run it does really predict. But yes, C peptide has a role in uh, detecting, diagnosing type 1 diabetes from type 2 diabetes. So, for example, if you're not sure if it's type 1 or type 2 diabetes and you're thinking of SGLT2 inhibitors, then that C peptide may help. If you're if you have an obese person with high blood glucose levels and you control the blood glucose levels, and if you're thinking of sending the patient for say bariatric surgery, then I think you need to look at C peptide, because if C peptide is low, may not cause a resolution of diabetes. So these are some reasons, but a great research question out there.
Absolutely, sir. And I think I must congratulate the audience for asking such a mind trickling question. Also, sir, that from your response, I was just thinking that our audience would also benefit if you could elaborate a little more on euglycemic ketosis, because that's the terminology that came up into light since the advent of the SGLT2 inhibitors and was talked quite a lot about and then got kindly subdued. So, your opinions on that one, sir, please.
So it's very rare. Number one, it's very rare. And number two, that SGLT2 inhibitors are great medicines, and the fear of euglycemic ketosis should not deter a doctor from prescribing the SGLT2 inhibitor, which can help, protect from cardiovascular, renal events, and all those in type 2 diabetes. Now, the important point is that SGLT2 inhibitors cause glucose loss in the urine. And when glucose is lost, the body starts burning fat. And when body starts burning fat, there is acetyl coenzyme A, acetoacetate, beta hydroxybutyrate. These are called ketones. They can increase in number. Now, when this becomes extreme, for example, if there is an infection or a sickness, or if the patient has got a additional sepsis, or if the patient is on a keto diet or intermittent fasting, sometimes a tipping point of this mild ketosis can be pushed into a euglycemic ketosis. How is it detected? I always tell my patients that please, whenever you are on this drug, if you get dizziness, shortness of breath, abdominal pain, uh, please monitor, get in touch with your doctor. And second thing is that you can always test and find out. Classically, the important thing, the crux, is that the blood glucose levels are not that high, but the ketones may be present in the blood. That is the crux of differentiating euglycemic ketosis, because sometimes it may just get missed. The patient may be sick, may be present to casualty, but if you take a history, patient has an SGLT2, if you do the blood ketones, they are high, and if you check the blood glucose, they aren't very high. That syndrome will pick up euglycemic ketosis for you. As I said, it's very rare. It's more of a clinical curiosity, and but it can happen, and we need to be aware of this.
Absolutely. So that's really, again, very well put up together. Thank you so much. I'm sure the audience will really benefit from this to use it clinically. Uh, so that really brings me again to my next point that I was thinking is that when we look at diabetes management, the usual way of monitoring is HbA1c or the lab tests that we do. And today we started up the point saying that monitoring itself in diabetes, when it comes to say the glucometer usage or self monitoring of blood glucose, is pretty minimal. And the study which I want to refer to here is the ICMR's INDIAB study, which was done 4 years ago by the government of India and our esteemed clinical panel of doctors across the states of India. And what we really found out was only 11% of the urban population was actually monitoring their glucose levels. And HbA1c has been denoted to be the gold standard for monitoring there. But what do you think when we talk about ketones? We said that there is acetone, there is acetoacetate, and there is beta hydroxybutyrate. If you had to choose one, and there is a published literature, what does literature and your knowledge and expertise talk about in terms of us picking up as the gold standard for ketone monitoring in diabetes?
Well, I think beta hydroxybutyrate is the ideal form of testing. The reasons for that are clinical, because beta hydroxybutyrate correlates very well clinically with the sickness and health of the person with type 1 diabetes. Yes, this study has been done in ketoacidosis, but as I showed you the data, as the diabetic ketoacidosis improves, the acetoacetate does not change to the extent that the beta hydroxybutyrate comes down. So considering beta hydroxybutyrates the ideal test which mirrors the patient's clinical situation, I would feel that it is the gold standard for ketoacidosis or ketoacidosis clinical practice. And wherever possible, I think it's important that we start using this test to benefit our patients with type 1 diabetes and also type 2 diabetes who are at risk of ketoacidosis.
Wonderful, sir. So I think it's really been an elaborate presentation for today, and I think it'll be really optimal for me as a role of a moderator to actually summarize the pearls of wisdom that I was talking that you have strewn across all of us today. So to start with, we actually wanted to cover, and we have covered today a topic which has really not been much in discussion, where we were trying to decode that what is the significance, the importance, the role of blood ketone monitoring in diabetes. And what we heard from Dr. Unnikrishnan here today was, one, if you can use monitoring in diabetes, there are chances that you can avoid hospitalization. There are chances you can avoid morbidity, mortality. You can actually impact on the economic factor because it kind of saves the cost of the patient when it comes to the indirect costs of hospitalization and complications management. We also looked upon at clinical pearls where we were thinking about what glucometer or ketone meter do we use. So there are in market available meters that have both glucose as well as ketone testing. So probably that is a good option to have at home, where you can check at the time or the convenience of the patient as well. We also heard from Sir that it would be nice to have, preferable to have at times, the single foil wrapped strips, so that we can have less contamination or less damage by exposure to oxygen, and so on and so forth. We also did hear that ultimately, as a responsible healthcare physician, we can ensure that we increase the rates of monitoring the gold standard beta hydroxybutyrate method for ketone monitoring across our diabetic populations, be it a type 1 or type 2. And I must congratulate, Sir, to you for clearly putting these down in a very simplified manner. This is not a topic that is covered each day, and this is not a topic that would have gone so smoothly without your lucid presentation. So may I request you for your final closure on to this particular session of today?
I think medical care is a mix of the best available evidence with clinical expertise and patients' preferences. So I think it's our duty to tell our patients about the importance of ketone monitoring at home. And it's also important that we place our clinical expertise, which we've experienced with ketone testing in the hospital, to make the patient aware of it. And of course, the guidelines, the American diabetes guidelines and other guidelines also endorse blood ketone testing and beta hydroxybutyrate testing as being important in the monitoring of diabetes, type 1 diabetes. And I think that it's important that we take steps to improve the general testing of glucose monitoring and ketone monitoring in our people with diabetes in India, because I think better monitoring is always good. I also take this opportunity to thank the Dr. Ritu for moderating. I'd like to thank the DocPlexus team. And my wishes also to all of you and also all the delegates and their families, during this time of the pandemic, and wishing everybody health and happiness and safety.
Thank you so very much, sir. And this cannot end without a very, very gratitude filled thanks to you on a Saturday evening. And I must tell this to the audience that it has been a very occupied week for you, but yet to remove the time and effort for this kind of a lucid presentation for the audience, so that even during these testing times, we continue to offer medical help to our patients of type 1 as well as type 2, and ensure to emphasize to them of how monitoring is also important for them as well. So thank you so much, Dr. Unikrishnan. No words can actually help you help us to put up the thanks that we feel internally. And I thank you also on behalf of the entire audience that is there on DocPlexus. Also thanks DocPlexus team for having us present this beautiful topic extremely flawlessly, and thank you for all the support. Thank you all for being a great audience. Thank you so much, sir.
Thank you and bye.